morning. Thanks again for having us here today, and thank you for Rev Johnson for your hospitality as well. And as we mentioned, a lot of the factors, the majority of factors affecting health aren't medical. They're the factors that our health ministries, social ministries have been doing a very long time. There's so much that we can all learn from each other here. And what we learned in Memphis was an incredibly inspiring way of aligning the efforts that we're doing in our churches and we're doing in our healthcare system to really be singing in tune, be singing in unison and at the same time. So all these parts are moving in unison. And if you want to go ahead and move to the next slide, what we learned from Reverend Bobby Baker, who was a part of the founding program called the Congregational Health Network, was a model that really we think can work here in Maryland, and we have a vision of implementing here both locally and across the state. So the next slide, it shows kind of what it looks like. It looks like a hospital entering into covenant with a congregation. And that covenant has responsibilities on both sides, right? So these things that we're already doing, really aligning them. What it means when a hospital enters into a covenant with a congregation there, next slide, says that the hospital is going to hire a navigator. And that navigator is going to meet with someone from your congregation whenever they're admitted to the hospital, every single day that they're in that hospital. And that navigator is going to talk with them about things that they need. Do they need someone to pray for them? Do they want someone to come and help them with transportation? Do you need someone to walk your pet or mow your lawn? What are these things that are on your mind that are preventing you from really focusing 100% on being healthy and continuing to heal? So that's the navigator's role. The navigators, which at Methodist Hospital in Memphis, they have 9, now work with 600 congregations throughout the region. And those congregations appoint a volunteer liaison. Can you raise your hand if you have a health ministry or a social ministry already in effect, or a nurse's ministry, something like that? Great. So in a lot of cases, it's that person. It's the person who's already doing the visitation, the prayer chains, making sure that so-and-so has a ride to their follow-up appointment. That is the ideal person who's the liaison. And the liaison and the navigator work together when someone from your congregation is admitted to the hospital on what is called a community care plan. Every day that the navigator is meeting with you in the hospital as a patient, they're going to say, would you like your congregation to be involved in your care? Is it all right if I call that liaison at your congregation to let them know that you're here and that you could use a little bit of help right now? Or maybe your caregiver could use a little bit of help and prayer right now? So after the patient gives the clearance to talk with the liaison, they kind of all meet together and say, what are the things that I need help with, and how can we meet these needs all together? And the impact of this process has been incredible. Not only, and we already know this, right? We already know prayer works. We already know that helping people take care of their basic needs works. But what we even see with the Congregational Health Network in Memphis is that when we're really working together and using these resources in a synchronized fashion, it has an even greater impact than if your church is praying for you, taking care of your needs over here, and your hospital's taking care of your medical needs over here. When everyone's working together, they saw improvements in mortality and in morbidity. They found improvements in the length of stay, of how long someone's in the hospital, how it was much more frequent for someone, or much more likely for someone to be able to take advantage of resources like hospice or other programs in the community, or even programs at the church, than if they weren't a part of this Congregational Health Network, even if they were an active part of their congregation. They saw that people who were a part of the Congregational Health Network, even when matched for age, health status, income, education, fared better because of this Congregational Health Network program, and that got our attention. The hospital spends about $600,000 a year on this program. Can you guess how much they save? $4 million. $4 million, that's coming out of our pockets, as patients, coming out of the hospital's pockets, coming out of even the church's pocket for all those miles driven to visit someone, all of those meals that have been made. It's a much more effective and efficient use of what we're already doing, these limited resources, to help us be better holistically, spiritually, physically, emotionally, everything in line, and because of how they've organized and committed to each other and entered into these covenants that were designed both by 100% by the pastors who are a part of it and the hospital that helps run it. So we know that it works. We know that it can work here in Maryland, where we already have such a strong faith community and such a strong, relatively strong healthcare system, particularly when compared to Memphis. We have so many stars aligning right now under this new model, and I was hoping that Rev Johnson would be able to come and share some of her reflections from our trip to Memphis, now that you know kind of the logistics of how it works, what we're kind of envisioning, and why we think this would work here in Maryland. So Rev Johnson.
Church, amen.
Amen.
Have you been informed? Have you enjoyed the information so far? I tend to be a practical person, and so I understand the language and I understand the theory behind everything that we've talked about. But my question is, so what are we supposed to do as church? What are we supposed to do as clergy? Why do we need this information, and what should we be doing with it? Oftentimes we come to these settings and it's a lot of information, but then what do we do with it to make a difference in our community? So when we went to Memphis, we went to, I don't know the zip code number, but it's the sickest zip code in the area and probably in the country. All the chronic diseases, they hit the mark at the very top. And the question is why, and what can we do to try to help that? And the Congregational Health Network was, I believe it was a doctoral dissertation by a young man, by a pastor. And so that's why there's a spiritual bent to it, which is what excited me. The church and the hospital working together. So the question I began to try to ponder in my mind is, so as a communicator, as a leader in the community, what can I do to make sure that the people in my pew or the people in the community are taking advantage of the changes that are going on in the hospital care? The first thing I think is that we have to begin sending positive messages out to our community about the importance of wellness and prevention. And so I thought that the model that they had in Memphis was very good at that, because you had clergy sitting down coming up with language. So I thought it would be good to interpret these kinds of things into sermons, into Bible studies, into Sunday school teachings, into vacation Bible school, into ministries, so that the language, we don't get stuck on language, but we get promoted or inspired to do. And so what they did with the navigators was so important, because the navigators understand hospital jargon. You know, all the things that the hospital are concerned about, which is important to keep that function going, because we have to have that institution in place. But somebody has to translate that from the hospital to the pews and to the community. So the navigators come and they understand hospital language, and they also they understand community language. Then they talk to the persons from the church, your ministry, your health ministries, and talk to them about taking care of the people. And so now you have a connection. And that's what really excited me, because there was one lady that was a navigator, and I think that her list, they gave her the 100, I guess, I don't know if this is good language, most chronic. I don't think that works, but
Familiar faces.
Oh, familiar faces, that works. But those are the persons that have been to emergency over and over and over again. That was their doctor. That was their healthcare provider. And so they gave her 100, the 100 person that abused the emergency the most. And she was able to create relationships. And to me, that's where the church comes in. Because we are in relationship with the persons in our churches. And we are in relationship with the persons who know the persons in our churches. And so by her having a relationship, she could talk to them on a personal level in terms of prevention. Did you go get your medicine after you came out of the hospital? Why not? Let's try to remove that barrier. I didn't have a ride. I thought if I cut the pill in half, or if I took it every other day, I thought if I took this one today, I didn't need that anymore, because I took my own pulse and it wasn't racing. Those kinds of things. But somebody has to be communicating on that level, somebody who the patient trusts. And that's where the church comes in, because people trust us because we are ambassadors for Christ. And so therefore I thought that if this was implemented in our community, And if we could get the hospitals to understand the importance of the navigators and hire people. Hire the person that can translate what the hospital needs to what's needed in the community. Then hire the navigators. You have to hire a director over the program so that the program is actually, somebody is managing the program, somebody is evaluating the program. Those type of things have to be in place. If we're going to just play at it, then I'll find something else to play with. But I just think that if in fact we're going to do it, then we ought to do it to the way that it makes a difference for our community. So some of the results they talked about were phenomenal. I believe that one of the ladies on the chronic care or the familiar face list had gone to the hospital. I think she had over 86 stays in a year, and she had cost her insurance company close to $1 million in care. And by instituting this program and by having a relationship with someone who followed her and cared for her and loved her and talked to her and inspired her and motivated her and encouraged her, then she began to back away from going to emergency to look for someone to care, to coming to a community person for someone to care. And out of that, she became healthier. And out of her healthiness, which is what the goal is to me, is that she becomes healthier, and the focus is on wellness, and so that not just her, but perhaps her children will be better because mommy's feeling better and mommy's at home. Perhaps her parents will understand that that hospital, which was down the street, a place that you never went to, I think it's our responsibility as leaders in the community to know about that hospital and to get on the boards of these hospitals and to bring our perspective to the hospital care. Because if in fact they don't hear from us, then they're wondering and they're guessing and they're taking evaluation on a piece of paper when as people who sit in the community, what needs to be done. I thought that if we could perhaps even begin to focus in our own churches on preaching and teaching about the importance of prevention. All of us kind of joke about the fact that, pastors go into ministry, and I think when you go to college the first year, you gain 15 pounds. They call it the freshman 15. Well, the pastors, if you probably look back, we probably all used to be thin. But it's something about that church environment where, we just don't eat right, we don't sleep right, we don't get our rest, we carry a lot of people's burdens, all of those things. But if in fact, I think if we can translate that and we begin to promote wellness first with ourselves, because everything begins in Jerusalem, and then you have to take it to Judea and then to Samaria. So we've got to get healthy ourselves. We've got to make sure that when we have the meals at our churches, that there's a healthy choice on the menu. We've got to talk about it. We've got to preach about it. We've got to pray about it. And then we've got to put in mechanisms so that persons do not feel alone. A lot of times people eat because they feel alone. They don't think anybody cares about them. They eat their own things. They eat by themselves. And so we got to begin turning our attention to those kinds of things so that persons in our churches do not feel left out and feel like nobody cares. And then we have to empower those people who we ask to head up these ministries. We got to fund them. They're in the budget and they don't have any money. And so we have to fund them out of our budget so that they can go and visit the sick. So that they can go and send a card. They can pick up the phone and call them. They can go and have Bible study at their house. Those things that is important to us as faith-based people, so that we know that the God that we pray to is using human hands to make a difference in how we feel. And we know when we have our spirit together that our health follows very closely behind it. And then finally, I thought that we should invite the healthcare professionals that are seated at the table and the people that work with them into our churches, so that we break down that wall of unfamiliarity and distance, so that we bring them in for our health fairs and we bring them in for our ministry meetings, and that we don't let them tell us, you only have 2 or 3 people, we're not coming. We're going to go knock on the president's door and say that you came to our meeting and said that you wanted to make a difference, you wanted us to help you. And so we have 2 or 3 people and you're saying that that's not important enough? Well, you don't know who those 2 or 3 people know. And so I think that we have to take leadership in our community to not only implement their plan, but that they're implementing the plan that we know that is important. So we're going to try their way, we're going to pray that it works, but if not, we're going to be in the middle of it, tweaking it so that it works to the advantage of our community, that when they count up the money and the insurance companies say, we saved millions of dollars. This was my issue, and I'm going to say it loud because I have the mic. The issue was that the insurance companies saved millions of dollars because of because the navigators are beginning to get people to not use the emergency. So my question became, if the insurance company saved millions and the hospital saved dollars,
Come on now.
where's the church? Where's the payback to the church?
That's right.
The people who are the forces on the ground. So if you want my church to be able to help you implement, then you may want to make sure that my church exists. My church needs help from you to exist, because we don't have the money that we need. We're barely paying rent. We're barely paying those necessary things. So let's take some of that millions and let's invest it back into the people that are on the ground called the church, so that we can go out and get a grant to establish a health ministry in our church, and then be able to disseminate the information, be able to bring in the professionals and do all those things, and then when the circle is complete, and then everybody benefits, and then I think that we have a good program.